enriching lives through innovations in healthcare. Every day, Getz Pharma begins with this vision. And every day is a new opportunity to impact thousands of lives. Getz Pharma has a very simple philosophy. We help people live healthier lives. Getz Pharma's mission is to develop, produce, and market safe, effective and quality medicines and healthcare products that improve the health and quality of life for men, women, and children. One of the top 3 pharmaceutical corporations in Pakistan, and among the fastest growing pharmaceutical in every country it operates in, we have touched the lives of millions of people. Through our journey, we have achieved extraordinary milestones because we have always put people first. We challenge ourselves, challenge the entire industry, and challenge the way people see problems related to healthcare. And we are nowhere close to being done. Our team of over 5,700 people drives this very change in over 22 countries around the world. Every single day, we develop over 542 pharmaceutical brands that cover a wide array of ailments in the spheres of hepatology, gastroenterology, cardiovascular, pulmonary, rheumatology, and infectious diseases. Behind this success is our organization's DNA, which is built around our strong employees. We invest in our employees' dreams that grow on to become their abilities. These are the hardworking men and women of Getz Pharma who have proven their passion and promise to developing the highest standard of pharmaceutical products. Getz Pharma promotes synergy of active talent at work, which results in a single-minded commitment to produce extraordinary results and achieve the highest standards of quality in all spheres. Our unique people and process paradigm helps achieve the twin objectives of emphasis on regulatory compliance and quality on one hand, while fostering innovation and creativity on the other. We believe in constant and periodical learning. As a constantly growing pharmaceutical company, we dedicate our time to contribute towards greater economic, social, and environmental goals. We develop safe, effective, and affordable medicines so the whole world can have access to life-saving drugs. Through our success, we have stayed true to the values that lie at the heart of our business, deeply influencing our research, products, and relationships with our partners. Getz Pharma, being the single largest exporter of pharmaceuticals from Pakistan, addresses differentiated and unmet healthcare needs through our new drug development initiatives. At Getz Pharma, safety is part of the corporate culture, and we embrace safety in all aspects, including infrastructural, employee, environmental, and community safety. The Getz Pharma Quality Control Laboratory, the only one in Pakistan and third in the region, has been pre-qualified, accredited and validated by the World Health Organization. Getz Pharma believes that a business is a potent social force by itself and is uniquely empowered to make a difference in people's lives. That's why our vision doesn't stop here. Getz Pharma is establishing the largest pharmaceutical plant to be constructed in South Asia at one site to cater to the ever-growing health needs of the region.
Our values are very simple. We'll have respect for people, our employees, our suppliers. They form the basis of our quality. Our people are very passionate. Passion is within our DNA. Passion to excel, passion to perform, passion to work together, and passion to enjoy while we are working together.
A business is about meaning, about values, a mission, a vision, enriching lives through innovations in healthcare. Every day, Getz Pharma begins with this vision. And every day is a new opportunity to impact thousands of lives. Getz Pharma has a very simple philosophy. We help people live healthier lives. Getz Pharma's mission is to develop, produce, and market safe, effective and quality medicines and healthcare products that improve the health and quality of life for men, women, and children. One of the top 3 pharmaceutical corporations in Pakistan, and among the fastest growing pharmaceutical in every country it operates in, we have touched the lives of millions of people. Through our journey, we have achieved extraordinary milestones because we have always put people first. We challenge ourselves. Challenge the entire industry and challenge the way people see problems related to healthcare. And we are nowhere close to being done. In 22 countries around the world. Every single day, we develop over 542 pharmaceutical brands that cover a wide array of ailments in the spheres of hepatology, gastroenterology, cardiovascular, pulmonary, rheumatology, and infectious diseases. Behind this success is our organization's DNA, which is built around our strong employees. We invest in our employees' dreams that grow on to become their abilities. These are the hard-working men and women of Getz Pharma who have proven their passion and promise to developing the highest standard of pharmaceutical products. Getz Pharma promotes synergy of active talent at work which results in a single-minded commitment to produce extraordinary results and achieve the highest standards of
Okay, good afternoon, everybody. Afolabi Babadide, I'm a product manager with Getz Pharma. It's an honor to have all of us here this afternoon. Why are we here today? We are here because of Getz Velocity. So the question is, what's Getz Velocity? So Getz Velocity is virtual engagement learning outcomes. So without taking much of your time, I would just like to invite our country head to give an opening remark for all our participants, speakers, and moderator as we start the event properly. So at this point, I'd like to invite Mr. Shudat Alkan, our country head, to give a short opening remark.
Thank you, Afolabi, and good afternoon, all participants. I must appreciate and thank you very much, Dr. Femi, okay, as a moderator, and thank you very much, Dr. Tijani, for your support, okay, to making us enable to do such scientific event. You know, after COVID, it was quite difficult to connect with the doctor. Even for the doctor community, it was really difficult to learn how they are used to continue their learning because there was no CME, there was no any event happening. So for this support, what we did, and we thank God that we are operating in more than 22 countries. So it make us enable that we could make a platform like a Velocity. You can see a platform where we are doing locals and international webinars to at least share the knowledge and learn from each other. So I think in this segment, like urology, we have our third session, and I think we did first in Abuja, then in Lagos, and now we are doing a webinar. So I must appreciate all participants. I thank you very much, Dr. Tijani. Thank you, Dr. Femi. Okay, we are expecting your support. Okay, now you will be delivering now. So the topic OAB, so maybe I will not go more scientific as I'm not doctor or I'm not pharmacist, but what I know in OAB basically a problem or disease is really for the female, particularly the elderly female, really compromising. So what I found in my opinion, I think we are lacking awareness, particularly in this segment. Awareness is not there. The women who deliver 2-3 maybe children's after reaching to 40 or 35, maybe people are thinking this is the situation, or maybe it happens naturally. they don't know is this is a disease or this is a problem can be treated. So I think I will also look into it with Dr. Tijani and also the Dr. Femi and other doctors. So what we can do to increase the awareness of this disease. So thank you very much. So I would like to over to Afolabi. Thank you, sir. I must appreciate your all participants. Thank you very much. Nice to see you or talk to you all. Thank you very much.
All right, thank you very much, Mr. Shujat Ali Khan, for that wonderful opening remark. Okay, so without taking much of our time, so the topic for this Velocity series is the role of primary care provider in management of overactive bladder disease. As we all know, we are at a time of COVID-19, and what does this mean? It means that there is limited access for some of our patients to the specialist. So what Getz Pharma has done is to empower the primary care providers by making the specialists actually impact on their knowledge. And we have noticed this is one area that there's been a knowledge gap. And I believe with today's webinar, we'll be able all to understand the clinical manifestation. Interestingly, we have a wonderful speaker and a moderator that will help us do justice to this. First, I would like to share the profile of our reputable family physician. His name is Dr. Olufemi Olowokere. So Dr. Olufemi Olowokere is a consultant family physician and geriatrician at the University College Hospital, Ibadan. He is currently the director of Chief Tony Anene Geriatric Center in the University College Hospital, Ibadan in Nigeria. And he is a fellow of West Africa College of Physicians with special focus specialty in family medicine. He's an associate lecturer in University of Ibadan College of Medicine, and he has a diploma in geriatric medicine in College of Medicine, South Africa. He's also a member of the Geriatric Association of Nigeria, and is also a member of the Society of Family Physicians in Nigeria. He's an associate member of the Royal College of Obstetricians and Gynecologists, excuse me, after gaining an additional qualification in reproductive health from the University of Liverpool, and is also a member of the Nigeria Institute of Chartered Management. So we have a family physician who is also a chartered member of the NIM, and also he has been involved in a lot of training. So he's also someone that is not just dedicated in having quality outcomes with patients, but he's also dedicated to the clinical practice. So he's involved in training of medical students and postgraduate doctors, and his interest area cuts across malaria, adolescent health, care of the elderly, and quality health care for his patients. He's an examiner with the West Africa College of Physicians and is involved in examining and supervising candidates at members and fellowship level. Dr. Olufemi Olowokere is happily married and is blessed with 2 kids. He enjoys reading, traveling, and listening. So at this point, I would like to give the floor to Dr. Olufemi Olowokere, who will be our moderator for today's webinar. Thank you for having you, sir.
Thank you very much. It's a pleasure to be here, and I want to welcome every participant. It's a pleasure to be on this webinar, and we will not waste any of our time. We will spend it very judiciously. But let me just quickly let us know that the role of this, the objective of this program, I will quickly give it to us before I give us the citation of just a brief bio sketch of our lead speaker for today. Number one is the objective is to help primary care practitioners understand incidence and clinical presentation of OAB, that is overactive bladder, which is very important for primary care physicians to have an understanding of. And also to outline management protocol in the management of overactive bladder. I will be using OAB instead of pronouncing it fully. I believe we all understand what we mean by that. And also to emphasize the safety and efficacy of solifin over other agents in the management of overactive bladder. And be that as it may, we've been told how the program will go. We're going to have, after the speaker, we're going to have what we call a journey to continence, a short presentation by the product manager of Getz Pharma for this product. And we're going to have some question and answer, which we're going to have some interactive section. And so I want you to begin to put down your question, begin to write it in the chat as the program is, as the presentation is on, because we want to get a lot of feedback so that we all benefit maximally. Then thereafter, we have a closing remark by Dr. Funsho Oloruntoba, the business manager. So that's just a short agenda. But quickly, because of our time, let me just quickly read the citation, or let me just say about sketch of our speaker for today. Our speaker for today is Dr. Kehinde Habib Tijani. He's an associate lecturer, professor of surgery and of College of Medicine, University of Lagos. He is an honorary consultant urologist and head of urology, Lagos University Teaching Hospital. He is presently the head of urology unit, LUT. In 1990, Dr. Tijani earned the MBBS degree from University of Lagos with distinction. He is a fellow of the Medical College of Surgeons, West Africa, and the West African College of Surgeons. He has held several positions previously as senior lecturer, lecturer 1 at College of Medicine, University of Lagos, and lecturer 2 at Bayero University, Kano, Nigeria. He pioneered the first successful renal transplant at Lagos University Teaching Hospital in 2011 and has about 3 decades of clinical experience, holding several positions in different capacities. He is also an examiner, Faculty of Surgery, National Postgraduate Medical College. His main research interests are reconstructive urological surgery, prostatic disorders, and andrology, and he has over 50 international publications to his name. He is a member of various associations, including Nigerian Medical Association, Nigerian Surgical Research Society, Nigerian Association of Urological Surgeons, British Association of Urological Surgeons, European Urological Association, and Society International Urology, SIU. And I wanted to just welcome on board Dr. Kehinde Tijani, who is going to briefly go through this very important topic, OAB, and also let us know how, as primary care physicians and healthcare providers, will be able to address this issue. Dr. Tijani, you are welcome.
Thank you very much. Okay. Well, while we sort out the technical issues. Yes. The host will need to do that.
Yes. He's the one that is.
Yes. He's not sharing the screen.
No, he is not. So you are supposed to be the one sharing it.
Yes.
It's calling him, man. Sorry about that.
Okay. Let's try it again. Okay. Good afternoon, ladies and gentlemen. I hope I'm clear.
Yes, we can hear you. We can hear you.
Yeah. Okay. So it's a pleasure to be here this afternoon to discuss this very important but commonly overlooked topic: overactive bladder disease, overactive bladder syndrome. Basically, of course, it's from the topic on its own. The topic itself is self-explanatory. We are discussing the role of the primary care physician, the general practitioner, or the family medicine physician in the management of overactive bladder. So my focus primarily will be the primary healthcare physician, even though it's my hope that everybody involved in the management of overactive bladder will benefit from this presentation. And that includes the urologist, neurologist, and so on. But I will try as much as possible. Okay, we hold on a bit. Let's minimize it. I'll try that. Screen sharing as well. Ask if they are seeing my screen. Okay, are they seeing my screen? Not yet. Okay, I should go to, because you are the host now. I have that message. Maybe you should cancel and try. Just cancel. Yes. Okay, let's see. So everybody's seeing the screen now. You confirm? Not yet.
No, not yet. We are not seeing your screen. Once you start sharing, we will begin to see it. Okay, you are sharing now.
Okay, very good.
Now you can maximize it now.
Yes. Okay. Okay. Are we okay?
Yes.
Okay. Again, I start on the existing protocol. This topic mainly, of course, from the title, it's basically targeted at the primary care physician or the family medicine physician. But basically, it's my hope that everybody that's involved in the management of overactive bladder will benefit from this presentation. So I'm going to be as simple as possible, with apologies to the urologists amongst the audience. So I will most likely, time permitting, I'm very likely going to explain some of the very technical details. Primary overactive bladder dysfunction. There are different definitions, but the more commonly accepted definition is the one from the International Continence Society. It's defined as a disease that is characterized by urgency, with or without urgent incontinence, usually with frequency and nocturia in the absence of UTI, that's urinary tract infection, or a known pathological condition. Now, for the non-urologist here, when we say urgency, of course, if you decide if you've taken 1 liter of water or 2-3 bottles of beer, and then you felt like passing urine and decide to hold on for 2 hours, naturally, by the time you go to the toilet, some urine may start leaking. That's not urgency. In urgency, within minutes, once you have the sensation of passing urine, most people will have an initial sensation of passing urine, and then this can build on for so long, for 1 hour or even more, before they have the strong urge, inability to hold it. In urgency, once you have that first sensation of passing,
Hello?
hello?
Okay, we are hearing you now. Hello, you can go ahead. We are hearing you now. Hello? Hello, Dr. Tijani? Hello? I think he's gone off. He's gone off. We have a lot of participants. That's over 103. I think one of you is with him.
Yeah.
They should sort it out. They have all gone off completely. Gone off completely. That's the thing about internet. It's always frustrating when it's this.
Mr. I hope the moderator, Dr. Lowe
Yes, yes, I'm
Yes.
hearing you now.
Yes, I would like to find out when I was lost, when transmission from my end was lost, because I was going on.
Just start from where you were trying to explain the urgency.
Okay. Okay. So as I was saying, in urgency, we are referring, when we say somebody has urgency, it means that the moment it has the first sensation of passing urine, it becomes so strong within minutes that it needs to go to the toilet, or else it will leak on himself. Now, that should not be mixed with somebody who has taken a lot of water, who now feels like passing urine, decides to hold on for 1 hour, and then when it is about to get to the toilet, urine wants to start coming out, or even urine starts leaking. That's not urgency. In urgency, the first sensation, within minutes, if you do not go to the toilet, you will leak. Now, when there is urgency and there is leakage, we call that urge incontinence. Now, so ICS over AOB basically is characterized by urgency with or without urge incontinence. In urge incontinence, it means urine, you know that urine is coming out, but you can't hold it. And also usually associated with frequency. Frequency at night, we call that nocturia. In the absence of known urinary tract infection or a known pathological cause. So in OAB, classical OAB, the patient has these symptoms, but you've also been able to eliminate UTI or known pathological disorders like neurological disorders and so on. But in reality, the bottom line, we are talking about OAB in terms of symptoms. So when we go further, I will explain what I mean. Now, it's very common. In the West, it's found in almost one third of patients. In some areas in the US, almost 40% of the patients after 40, men and women, present with 1 or 2 symptoms of AOB. Of course, it's significantly underreported in our environment, and that's one of the gaps that Getz Pharma is trying to sort out. And there's a significant negative impact on the quality of life. You can imagine somebody who has been active now being unable because he knows that he would need to pee every 30 minutes. He's unable to travel long distances. He's unable to go out without wearing diapers. So it's very significantly affects quality of life. And now the primary healthcare physician, or maybe interchanging with the GMP, general medical practitioner, most times is usually the first contact of the patient. And that's one of the reasons why this topic is important. Now, what are the treatment gaps? Why are patients not having treatment, adequate treatment, and at the appropriate time? A lot of patients suffer in silence, as I've said. A lot of patients are afraid to actually approach the primary care physician because many of them have had the belief or have the belief that the investigations are complex, they are invasive, and he or she may need to have surgeries. And some of them actually believe that there is no treatment. So they just decide to live, manage their life, adapt, and suffer in silence. Now, who manages OAB? Traditionally, OAB was managed, was considered the domain of the specialists, usually the urologists, urogynecologists, and occasionally the neurologists, but not the primary care physician. Now, why? Why was this so? was because initially, even when I was a resident, whenever if you read any book or any journal on overactive bladder, you will be perplexed by the number of extensive investigations. So generally, before now anyway, anybody with overactive bladder was bombarded with a lot of extensive and complex investigation. And of course, a lot of PCP, now that's primary care physician, also had limited training in urological disease. So it's easy. If you are in your comfort zone, a patient now comes with something that you assume is complex. The easier thing is for you to just refer. And that's what anybody will do. So, however, the recent consensus have described a simplified approach to AOB that does not require and does not involve complex testing, particularly in complicated cases, so that it does taking the primary care physician to the forefront. And again, I must emphasize again, that is the focus of this presentation. And that is what Getz Pharma is trying to encourage. Of course, again, this also explains one of the reasons for the treatment gap, as Dr. Oluwakere would know. The range of diseases that the primary care physician or the family physician treats is increasing every day, and likewise the time available for each patient. So again, when you add that to the relatively poor urological training, it means just one thing: there will be underdiagnosis and there will be under-treatment. Now, I mentioned the fact that OAB significantly affects quality of life, but it's not just that alone. These patients the records are there, the studies are there that patients with AOB have higher risk of falls, leading to fractures. And it's common sense. A woman that needs to rush to the toilet every 15 minutes ultimately is going to be prone to having a fall. And as you and I know, fall fractures in the elderly can be very, very debilitating. A lot of them may never walk again. And of course, patients with overactive bladder, particularly there's significant urge incontinence, there's risk of urine soiling, the perineal area, wound breakdown, and then infection. So it's not just quality of life alone, even direct medical effect on the patient. What are the objectives? I think by the end of this short presentation, I hope that the primary care physician should be able to identify patients at risk or identify patients with OAB, present therapeutic options to these patients, and to also recognize when it is appropriate to refer to a specialist. Now, there are some definitions I've listed here, just to make it easy. But the urologists on the platform, they know that this is not entirely exact, but for the purpose of this audience, this is we should understand. When we say frequency, you are referring to voiding more than 8 times a day. I will explain why this is being used. And then when we talk about nocturia, we are referring to somebody voiding more than once per night. Normally, you should not void at night, but if you void once at night, that's acceptable. But once it's more than once, that's nocturia. I've already explained urgency. Now, incontinence, basically, we all know that one, what it means. Involuntary loss of urine. You are unable to control the urine. If the incontinence is preceded by urgency, in other words, that sensation, you know the urine is coming out. That is what is called urge incontinence. Now, if it is not preceded by urgency, it is preceded by increased activity, like coughing, sneezing, laughing, or physical activities generally. That is stress incontinence. And we must understand that the overactive bladder syndrome, a lot of patients, particularly women, there's an overlap between the AOB and stress incontinence. Many patients will have mixed. They will have some urge incontinence, will have some AOB symptoms, and may also have some stress incontinence. So when you are going to manage these patients, you have to take that into cognizance that a lot of them will come with some form of mixed incontinence. Now, again, this is, again, something we should, now these symptoms, let's go back. The symptoms are listed: urgency, frequency, nocturia. We generally call them storage symptoms or irritative symptoms. But you must also realize that when you see patients with storage or irritative symptoms, you must specifically also look for the obstructive symptoms, because this will guide you in your diagnosis, it will guide you in your therapy, it will guide you on whether to decide to refer the patient or not. Now, the obstructive symptoms, I listed some of them. Hesitancy, that's the man goes to the toilet. The man goes to the toilet, he realizes that despite the strong urge, when he gets there, the urine now he needs to wait for 30 seconds, 1 minute before the urine starts coming out. Poor stream, intermittency, and then feeling of incomplete voiding. So you must look for these symptoms. I've mentioned this. Now, again, I said 1 in 40. I mean, 1 in 3 adults, that's 33%. So what we are saying is that OAB is actually more common than diabetes, asthma, coronary artery disease, and prostate cancer. So it is extremely, extremely common. So, okay, I've mentioned something about treatment gaps. Most of the patients delay discussing it with their GP. Okay. Now, this is a simple algorithm for the GP. We'll probably talk about it more. That is, when you see the patient, what we are trying to encourage in this presentation is that the GP should not wait for the patient to actually complain, because most patients, as I've said earlier on, have different beliefs. Some of them will just decide to live with it. So the GP should have simple, the care approach is that there should be simple evaluation and providing safe and effective treatment options. We will expect the GP to understand the symptoms, elucidating the cause, and commencing the empirical treatment when urological and neurological cases are eliminated. And we expect the GP to differentiate between the storage and voiding symptoms. Now, basic workup, when you see the patient, it's important now, what we are trying to emphasize by this presentation is that we should not wait for the patients to actually give us those complaints, because we're talking about 1/3 of men have symptoms of OP, and a lot of them will have accepted it as normal. However, it is our duty as practitioners, first-line practitioners, to screen patients for this. So these are some of the questions you need to ask the patient. How many times does they have that sudden urge to go to the bathroom and they cannot? Does it leak? Now, you can just look. These are the first two. Basically, these are overactive bladder symptoms. You have uncontrollable urge to urinate. That's urgency. We urge incontinence, which again can be in OAP. You leak on the way to the bathroom. I think we can just have a look at this. These are, do you leak when you laugh, cough, or sneeze? That's basically to eliminate, to detect stress incontinence. And as I've said earlier, a lot of patients have these symptoms. Now, once you screen this patient, you've asked these questions, and you've identified that the patient has overactive bladder syndrome, or overactive bladder. What exactly is next? So what exactly is next? You need to take a good history, good physical examination, thorough physical examination, and then limited laboratory evaluation. Now, what are you looking for in the history? You're looking for transient reversible symptoms. Some patients may just have some of these symptoms, particularly the urgency, urge incontinence, just for a particular period. But the bottom line, usually once patients have one of the overactive bladder syndrome, even when the symptoms disappear, they are very likely to have it in future. You try to look for temporal relationship between the symptom and any change in medical social history. For example, if the patient associates the symptom with an environment, associates the symptom with diet, associate the symptom with drugs. So you associate the symptom with a new diagnosis. Maybe it's just been recently diagnosed as being diabetic or being hypertensive. Then you need to ask about the past medical history. Diabetes, congestive cardiac failure, that's whether he has orthopnea, PND, renal disease, neurological disease. You need to ask about dementia, Parkinson's, stroke, because these are disorders that can make patients present with symptoms of AOB. And needing of course, when you take this history, you'll be able to determine whether it's a patient that you can manage or a patient that needs to be referred. You need to also ask about prior surgery, patient has had prostate surgery, bladder surgery, gynecological surgeries, because these patients truly can present with symptoms of AOB. And then drugs, particularly drugs. A lot of drugs interact with bladder function. I think there's a slide there. This is a slide. You can't go through everything, but you can see that a lot of antihypertensives can actually affect urinary function. Some of them may cause frequency. Some of them may actually cause obstructive symptoms. Some of them may cause irritative symptoms. So we should take note. Usually, this list is not exhaustive anyway, but we must particularly ask our patients about their drug.
Hello, Dr. Tijani. Hello, Dr. Tijani. We are not okay.
Hello?
Yes, we are hearing you now. We lost you just some few seconds.
Okay, I think it's the connection.
Okay, it's okay now.
Okay, now, so basically focus on anomalies that can influence the symptoms. Neurology particularly, make it a habit. When a patient comes to your consulting room, or when you are going to examine a patient, let the patient walk. A patient, by seeing a patient walk, is enough to eliminate a lot of things. So if you can see the patient when he's coming into your room, fine. If you did not, it's always better to ask the patient to just get up and walk. Look for facial asymmetry, which may also indicate stroke, obvious limb, or poor physical coordination. Alertness, memory, this may indicate issues with dementia. Then you must measure the basal mass index. It's an undisputed fact that BMI, increased BMI, is associated with incontinence in women, which may be commonly stress, but can also be urge incontinence. And one of the things, if the BMI, particularly BMI greater than 30, so, and as a primary care physician, once you see a patient like that, there is absolutely nothing wrong in advising weight loss. Even if that doesn't solve the problem, it will assist. Then you must examine the abdomen thoroughly. You want to palpate masses, you want to palpate hernia orifices, distended bladder, which may indicate obstruction. It may indicate a prostatic disease. And prostate particularly, even though theoretically it's an obstruction, patients may actually present with just symptoms, irritative symptoms, symptoms that are just similar to overactive bladder. So you must examine the abdomen, look for a distended bladder. For the women, you want to check the vagina, look for prolapse, and then check the anal sphincter. But when the patient comes to tell you that he or she is unable to pass urine, by just check, he's unable to hold on to urine. By just checking the sphincter alone, may give you a clue, because maybe she's neurological, something coming from the sacral nerves, S1, S2, S3. Some of these patients, you may also notice that there may be laxity in the anal sphincter, even though they've not complained of incontinence of feces. Simple cough test. This may assist you to eliminate associated stress incontinence. For the male, DRE is very important. You want to examine the prostate, and you should look at the perineum, whether there is a scar, which may indicate either previous surgery, urethral stricture, which basically, and I will continue to emphasize, these are obstructive disorders, but a lot of them present with irritative symptoms. So after you finish examining the patient, what are the investigations? I'm not going to go into the very complex ones, the urodynamic studies, but basically the simple investigations, these are the simple investigations recommended, particularly for the primary care physician. Simple analysis. You want to examine the urine analysis, you want to look for blood, protein, and glucose. Usually, if urine analysis is normal, it's enough to eliminate bladder cancer, stones, UTI, except diabetes, because you know that for diabetes, a high blood sugar doesn't necessarily mean that the patient must have glycosuria, because basically the blood sugar must be usually more than 180 milligrams % before the patient starts leaking sugar in the urine. So, but disorders like stone, bladder cancer, UTI, because basically these disorders, patients with these disorders will present typically at the early stages with symptoms of that resemble AOB. Fasting blood sugar will help in eliminating diabetes. And then if you think the patient has an obstruction, you can do urea and creatinine and upper tract ultrasound scan. Now, this is an important investigation, the bladder diary. Okay, the bladder diary. Now, there are different forms of bladder diary, but the basic thing about bladder diary is letting the patient to have a diary to take note of the time, the times, and the number of times he or she passes urine, and whether there is urgency. You may also be able to ask the patient to estimate the volume of the urine if it is possible. But the bladder diary is very crucial in identifying contributory social factors and habits. And we also significantly assist in the management of these patients. Another investigation that's very useful is to assess the post-void urine. That means a lot of patients complain that they pass urine frequently, and they have strong urge to pass urine, whereas the problem is obstruction. And what's happening is that because the individual is unable to empty his or her bladder, once the urine joins that person needs to go again to pass urine. So the individual presents with frequency, even though the problem is obstruction. And so that's why it's crucial when a patient presents with OAB symptoms, you need to assess the post-void urine. A simple way is really to do an ultrasound scan. But if you feel that the patient is cooperative, you can also catheterize. That means you ask the patient to pass urine and then you do an ultrasound scan. Then there's urine flow. Uroflowmetry, if you have it, you do it. But a simple way to assess whether this patient has a good stream is to actually ask the patient for the arc. You know, if you pass urine, if your stream is good, the urine comes like an arc. Whereas if the flow is very bad, you start dribbling on your trousers or even on your shoes or toes. So basically, you can ask for the arc. If the patient tells you that he has a good arc, it's very likely that the flow is good. But if you have a uroflowmeter, you can go ahead and do it. Now, there are other investigations, urodynamic studies, cystoscopy, fluoroscopy. I've left that because basically we do not expect the GP or the primary care physician to do this. So, but the earlier investigations from urine flow, ultrasound scan, those are investigations that I think a primary care physician should be able to at least recommend and manage. When do you refer the patient to the urologist or the neurologist? One of them is when you are not sure of the diagnosis. The patient has symptoms, has some other symptoms, particularly he has OAB symptoms and significant symptoms of obstruction. Then it's better for you to refer. Field therapy, you've offered the patient treatment. Somebody's raising his hand again. Okay. Failed therapy, hematuria. I mean, if you've offered patient therapy and it fails, patients presenting with blood. Because most times in urology, whenever there's hematuria, we are usually very concerned that it may be a sign of something that is much more devastating. If the patient has had previous bladder surgery, then you should consider referral. Other indications are listed below. Now, quickly, because my time is almost up, the catheter-related bladder discomfort. Now, catheter-related bladder discomfort, I'm sure almost every physician would have managed somebody on a urethral catheter. And almost every physician probably will have encountered these patients complaining of discomfort, despite the fact that there is no blockage of the urine. Now, that is what we call a catheter-related bladder discomfort. That is, it is characterized by suprapubic pain and a strong urge to pass urine in the presence of an indwelling catheter. Now, in the presence of a patent indwelling catheter, that means the catheter is draining, but the patient is complaining. The symptoms resemble AOB, and they are basically mediated by the same receptors. A lot of physicians, when they see patients with complaint of catheter-related discomfort, end up giving, some will give antibiotics, thinking it's from an infection. Some will give painkillers. Most times these painkillers are not very effective. The worldwide incidence of CRBD is unknown, but it is obviously very common. Generally, it's graded into mild, moderate, and severe. Usually, the typical mild case is usually the one that the patient complains with. Usually, when you're asking patients about symptoms and the patient complains about it. Whereas in severe cases, the patients, particularly patients that are admitted on the ward, make direct attempt to pull off the catheter. Or some of them will actually tell you that they prefer to die than to be on the catheter. So there are different grades. As I said, analgesics will not be enough. The drugs for OAB, particularly the antimuscarinic drugs, have been found very effective. The studies are a bit conflicting on whether these drugs reduce the incidence. But one thing that is for sure, all studies, including even the one done locally, have showed that when you give antimuscarinic drugs, the severity of AOB, the severity of symptoms, CRBD, is significantly reduced. And if there's something that I want us to go away with at the end of this presentation, is to realize that CRBD can be managed with antimuscarinic drugs, rather than just reassuring the patient and telling the patient that shouldn't worry, the pain will go, or just giving analgesics. Now, what are the treatments for OAB? One of the things we should note is that not all patients will desire treatment. Some patients simply come to you as a primary care physician because they are worried that their frequency may be a sign of one terrible illness, maybe cancer or something. So usually such patients, reassurance will just be enough. The other things you can also offer these patients, behavioral modification. Advise them on pelvic floor exercise, bladder training. Bladder training in this case, that we should tell the patient to try as much as possible to time his urination, to delay his urination. Maybe start with maybe 30 minutes or 1 hour, every 1 hour, whether it feels like passing urine or not. You can then extend it to 2 hours, 3 hours. Then if you have a patient that can actually hold on to urine comfortably for 3 hours in a day, I think you've done well as a physician. So bladder training, that means timed voiding. Then weight loss. Patients who are overweight, particularly women, should be encouraged to lose weight. There are drugs, drug therapy. The main aim of the main objectives of the drug therapy is to reduce urgency, increase bladder capacity, and then increase interval between voids. I'm not going to go too much into details, but the two main drugs, the two common categories of drugs we use, antimuscarinic drugs, there are so many of them. Of course, sulfenacin is probably one of the mainstay of the drugs. And then the beta-3 agonist. The only one that's presently licensed is mirabegron. The main disadvantage of the antimuscarinic drugs or the side effects: dry mouth, constipation, and blood vision. You don't give these drugs when a patient has closed-angle glaucoma or bladder and gastric outlet obstruction, because if the patient has an obstruction, particularly bladder, some evidence of obstruction, you give an antimuscarinic drug, the man will go or the woman will go into acute retention. Mirabrigon can increase blood pressure, can give headaches. Those are some of the side effects. There are other forms of therapy for overactive bladder. I don't want to go into details about them, but those probably will be within the realms of the specialists. But this will include sacral nerve stimulation, bladder augmentation surgeries, botulinum injection, and the rest. Now, this is a simple algorithm. I can't go into it, but it's basically a summary of all I've said. Okay, these are the red flags, knowing when to refer secondary care. So I think my time is basically up. The floor will be open to.
Yes, Dr. Tijani.
Yes. So I think I will stop for now.
Let me just give you 1 minute to do a wrap up.
Okay.
Just 1 minute. Is
Okay.
that your last slide?
Yes, my last slide.
That's your last slide.
Yes. So basically, this is basically a summary of all I've said. When you take a good history from the patients, when you've taken a good history, you just know the red flags. These are the red flags. When you see any of these red flags, refer. When you have a patient that is not responding to a treatment, that's not responding to a treatment, you refer. Now, again, if offered treatment, if there is no improvement, let us say you have tried an antimuscarinic drug, there is no improvement, try a beta-3 agonist. In practice, most of us go to the antimuscarinic drug before you go for beta-3 agonist. But you can go either way. So if you try one, it doesn't work, you try the others. If there is no improvement, as I said, then refer. Thank you very much. Okay.
Thank you very much, Dr. Tijani. I want to sincerely appreciate you. And in fact, as many people, I know that there are many audience, variety of audience on this platform this afternoon. We have family physicians, some nurses, some pharmacists, some gynecologists. I know some urologists too might benefit from what we are talking about today. It might look basic to them, but we should always start from the basic before we move on to the complex situation. Thank you once again. Let me just quickly give you a summary of what Dr. Tijani has said. He has done very much justice to this program, to this topic. Very important topic indeed. And he started by telling us the objectives and also made us to understand the the definition by the International Continence Society. And they gave that definition as one important point that we must note here. It said urgency, with or without urge incontinence. If we don't pick anything, we should pick that. He also made us understand that usually there is frequency and there is nocturia. And also there might not be proven infection or on any obvious pathology. So I think we need to get that in as one important point that he raised. The other point I must also say is that urgency is a key symptom. Urge could be normal, he explained it, but urgency could be pathology. So we should note that also. And he was able to also explain to us frequency when it's greater than 8 times. For at least for primary care physician, we should know that. Nocturia when it's greater than 1 time. Then he talked about the involuntary loss of urine, which is the incontinence. Then he also made us to understand what the prevalence. I'm not going to go over his presentation again, but I'm just going to highlight the important point. He talked about the prevalence in the West, but one important point that we must know is prevalent both in men and women, and it will increase with age. And also, one thing that we must know is that as primary care physicians, whether we like it or not, these are going to be presenting to us. So we are the first contact doctor, and they are going to present to us. So it's syndrome of a symptom of syndrome that we must all have an understanding of. Then he also talked about some of the things that happen, that patients that suffer in silence because they might not want to come. They are afraid to approach the primary care physician. There is fear of a lot of investigation. Of course, in this part of the world, they will tell you to go and do a lot of investigation. And some people actually believe there is no cure. And so we must have that at the back of our mind. And also, he emphasized something about the treatment. I must sincerely appreciate Dr. Tijani because of the way he has identified the role of this primary care physician in the management. Traditionally, it is believed that urologists and the urogynecologists are the people that should handle this treatment. But we all know that things are moving now, is shifting. If we leave everything to them, I can assure you we are going to have a lot of problems. How many of them do we have even in the country as we're talking? So they need to empower the people that will make their job easier. We who are the primary physicians and the primary care physicians. And he also made us understand historically there is a lot of extensive and complex investigation that could be done. And also there's limited training for primary care physician in neurologic disease, which is very obvious, of course. And most people will just want to refer once they see. But I believe that with this presentation, quite a number of people will be confident enough to be able to approach it without any fear. And he also made us understand that AOB significantly affects quality of life. I must say that I'm a geriatrician, so I understand every aspect of this that he's talking about, especially when it comes to medication issues. He talked about the risk of falls, that will lead to fractures, risk of infection in them. Then he made us understand that we need to be able to identify patients at risk and also present some therapeutic modalities for them, and also when are we to refer. That is an important point. When are we to refer? He was able to differentiate between urge incontinence, stress incontinence, mixed incontinence. But one important point is that we must know that there is mixed, most times, a lot of this come with mixed symptoms. So it's not just you looking for one thing and you make your diagnosis, just like the algorithm that, the screening test that he showed us. Then he also emphasized the issue of storage symptoms and obstructive symptoms. We must have that at the back of our mind. And he said that OAB is more common than diabetic mellitus. Of course, because we don't think about that. And the asthma, chronic artery disease, and many other non-communicable diseases that we are conversant with. Then he also explained to us the algorithm that might be useful to us. He told us about simple evaluation. One thing that we must know here is that don't wait for the patient to ask you. Don't wait for the patient to present to you and begin to tell you about OAB. You must go ahead and ask for it. So, in fact, studies have actually shown that most times, most doctors don't ask about OAB. So, it's on both sides. So, we should know that very importantly. Also, it differentiated between storage and voiding symptoms. And so, he said we should know that. Then the basic workup, he told us about good history, and he expatiated so elaborate on that. Then the physical examination, those things are very key. Then the limited laboratory investigation that we have. But as family physicians, we must be able to just go ahead and do simple investigation as urinalysis. And he emphasized that we will be able to exclude the bladder cancers, UTI, and accept the diabetic mellitus, but full blood count and the likes. And he said if primary care physicians suspect obstruction, there are other investigations that you need to do. And he was able to actually explain that. Then he talked about the CRBD, the catheter-related bladder disease. Am I right? Yes. So he emphasized that, and he told us some things about that and how to differentiate. Then later he now talked about the treatment. I'm going to conclude on that so that I can give our participants the opportunity to ask questions. He emphasized that not all patients desire treatment, which is very true. In my own little experience, it is very true. Religious-wise, cultural wise, in our own environment, people don't, some people will just want just to have information, and we should know that. And he said sometimes it's just reassurance only after they have, I mean, you have been able to interact with your patient. Then the other aspect he emphasized more importantly is the behavioral modification. And I think that aspect is one important area that we must all look into, behavioral modification. Talked about the pelvic exercise, bladder training, and also we must encourage them to lose weight. Then finally, he talked about, before that, before I, sorry, let me just quickly talk about one important thing that I missed out here, when to refer. When to refer. Number one, uncertainty of your diagnosis. You are not certain about your diagnosis. There is a failed therapy. If there is hematuria, and emphasize why they are, as urologists, are very conscious, I mean, very, that they take cognizance of hematuria. If there is recurrent UTI, or the patient has previous bladder or urethral surgery, and also if there is a raised post-void urine, I mean, residual urine. So we need to take cognizance of that. Then finally, it's on the medication now, the antimuscarinic drugs, and it made us understand that these drugs are important, but at the same time, be careful, they have contraindication. Take your very good history. Don't give it to a patient with close angle glaucoma. Don't give it to a patient with gastric or bladder state obstruction, and because you can cause more problems. And there are side effects, especially in the elderly and some other women too. I mean, pre or post-menopausal women that are already having their problems with dry mouth. With this medication causing their dry mouth. So when they complain, you should have an understanding of this. Constipation, blood vision. Then you also talk about the beta-3 agonist, the mirabegron, and all the other things that can be used. So let me just, that's by and large, majorly most of the things that he has talked about. I won't go about the catheter-related bladder discomfort again. Let me leave that, but let me give the audience, I believe many questions will come so that they can have an idea of what is happening. But before the question, I think we'll quickly move on to the next presentation by the product manager of Getz Pharma, Mr. Bankole Kennedy. Can we have you on board, please, while we are getting ready the questions?
Okay. Good afternoon, everyone from Getz Pharma Nigeria House. I bring you greetings. It's a pleasure to be here talking to healthcare professionals around Nigeria. Thank you, Dr. Tijani, for the wonderful presentation, and thank you, Dr. Olokere, for summing it up in a very nice way. We remain unwavered in our commitment that every Nigerian should be able to access quality healthcare, quality medications, irrespective of their social status. That is why our manufacturing site, pre-qualified by WHO, continues to help us in the manufacture and supply of these quality medications to Nigeria. As of today, we have over 55 medications, SKUs in the country, and more are still coming in. So in the next couple of minutes, in the next 5 minutes, we'll be looking at a patient who, like Dr. Tijani said, exhibits symptoms of OAB, incontinence, frequency, nocturia, and how you are going to help such a patient when such a patient presents at your practice, primary care specialist. How would you want to help that patient? At the end, probably some offer better efficacy, but definitely some offer better tolerability in the management of OAB. So Mrs. Gilbert is your typical 40-year-old woman with a 2-year history of progressively worsening urgency. She has hypertension. For the last 6 months, she has begun to have urge incontinence. She consistently experiences this during sexual intercourse. And of course, she has frequency and nocturia. On physical examination, you realize that she does not exhibit any stress urinary incontinence. Urinalysis is negative. Over the course of her treatment, she has tried non-pharmacological therapy, like Dr. Tijani mentioned, but derived no significant improvement from this. If you were the primary care prescriber or physician with Mrs. Gilbert, well, how would you want to help Mrs. Gilbert? Definitely with a patient like Mrs. Gilbert, you want to align on what the treatment expectations are, so that the Mrs. Gilbert is thinking it's a condition that within 1 week, once you give a medication, she's going to start having better symptoms. You want to align on when medications will start to kick in, how soon and how effective those medications. You want to also help treatment compliance by prescribing a medication that does not have so much side effects, and of course reduce or eliminate those symptoms. The goal is to have efficacious medication with less side effects. So generally, like Dr. Tijani said, the mainstay in the management of overactive bladder still remains anticholinergics. And among the anticholinergics, we have the older one and the newer one. And some of the newer ones are sulfenacin. All guidelines indicate that first-line treatment when non-pharmacologic therapy fails, or when non-pharmacologic therapy is inadequate, that is where, should be anticholinergic medications. So why anticholinergic medications? It's basically because muscarinic receptors are primarily responsible for the detrusor activity of the bladder. Those muscarinic receptors mainly are the M2 and the M3. Don't forget that we have 5 muscarinic receptors, but basically the ones found in around the kidney are the M2 and the M3. But amongst these, it is the M3 which makes up 20% of those muscarinic receptors that is believed to be the main receptor subtype responsible for normal maturation and contraction. So allow me to introduce to you Solifen. Solifen is a once daily medication from the stables of Getz Pharma. It is the first sulfenacin succinate that came into this country registered. Solifen has proven efficacy in patients with overactive bladder. So it is not you would definitely want to win with Solifen when you have patients with overactive bladder. Then why Solifen? Because as we can see on these slides, overactive bladder involves decidual muscle contracting even before the bladder is full. And that is because of the overactivity of the M3 receptors. Once you give Solifen, it relaxes those detrusor muscles to make sure that it becomes as normalized as possible, such that it will take a longer time for the bladder to be filled up before contracting and sending those signals for urination. And that is how Solifen works. And what this involves is because of the selectivity of Solifen for M3 receptors, which makes up just 20% of the total muscarinic receptors in the bladder. It gives better tolerability and it is fit for long-term use in the case of a chronic condition such as overactive bladder. Studies have confirmed that Solifen is not only superior to first generation anticholinergics such as tolterodine. It's also, of course, superior in versus placebo in studies. So, in summary, to re-emphasize why Solifen offers advantage over conventional anticholinergics, it is because it is selective, it is because it is effective, and it is because it is safe. So, what is the dosage recommended for Solifen? Like I mentioned earlier, Solifen is a once daily medication given once daily. If need be, after 1 month and there is no significant improvement, this dose can be increased to 10 milligrams once daily in certain patients. So what is the news now? I'm happy that Mrs. Gilbert now enjoys a normal quality of life. She does not wake up at night to urinate frequently. She does not have these urgency or the leak that experiences, incontinence, and now frequency is between 4 to 5, which is normal in a single day. So, like I mentioned earlier, Solifen is safe, effective, and selective. So that's all from my end. Thank you very much, everyone, for paying close attention. I hope that at the end of this presentation, you would be able to place your patients on Solifen so that they can benefit from this medication, which Getz Pharma has tried so much to bring into this country. Thank you once again.
Thank you, Mr. Kehinde, for that short presentation on journey to continence. Let me just quickly now bring up some of the questions. I know the participants are eagerly waiting to have a response to their question from our lead presenter, Dr. Kehinde Tijani. Now, Dr. Kehinde, are you listening to me? Dr. Tijani?
Yes, I'm listening.
Okay. Now, let me start with the first question. We have a number of questions here. That means that people have listened with rapt attention, and also the fact that we have varied participants, so from different backgrounds. So you must bear that in mind when you are answering your question, because you will see from the question. The first one says, what is the difference between OAB and prostatic enlargement?
Okay.
Now, let me give you two questions. No, let me give you two questions. So you take two. The second one says, well, this one has been answered. Say, what are the drugs that can be used in OAB? I know that is answered already, but you can emphasize. So just take those two ones on before we move on to the next one.
Okay, well, basically, OAB is defined basically because of its symptoms. That means the individual has urgency, frequency, may have nocturia or urge incontinence. Prostatic enlargement is one of the diseases that can make a patient to have symptoms that you find in OAB. And also I was talking about obstruction causing irritative symptoms. So prostatic disorder is just one of the causes. Urethral stricture can cause symptoms of OAB. So they are totally different things. So when you have a patient who has symptoms of OAB, you must try and eliminate whether the prostate is one of the causes of those symptoms. That's basically, I think that's probably the easier way to explain. Drugs that can cause OAB, different drugs, but drugs that can be used to treat OAB, different drugs, but as I mentioned earlier, first line of drugs usually are the antimuscarinic drugs. Presently, the beta-3 agonists have been licensed, particularly mirabrigon. Those are the common drugs. I don't think we should go into the more complex drugs, but those are the two common categories of drugs that we can use to treat OAB.
Okay, Dr. Tijani, thank you very much for those answers. The other one is, how do you rule out UTI with only urinalysis? That's the first one. Then the second one that follows is, there are other drugs that can cause OAB, apart from treating it with a particular medication. Do we have some other medication that can cause it? So maybe you should answer those two, then we'll move on to the next one quickly.
Okay, I think first of all, when we say, okay, again, I think I was speaking as a urologist. When we say urinalysis in urology, it's not just the kit, the chemical kit. We're talking about analysis of the urine, which also will include microscopy, culture, and sensitivity. But however, with the kit, by the time a lot of patients who will have UTI, you may see some things in the kit, a lot of nitrites and so on. But when we talk about urine analysis or urinalysis in urology, you're not talking about just the biochemical alone. It also includes urine microscopy, culture, and sensitivity. Drugs that can cause AOB. Well, I don't want to use the word that can cause AOB. I listed a list of drugs that can give symptoms. that will give symptoms some of the symptoms you find in OAP. An example is simple diuretic, antihypertensives. If you give somebody a drug that's not making him to pump urine out, that individual who was probably waking up once at night will wake up 4 times at night. And if the volume is so high, that individual will have some urgency. So that's just an example. Drugs that will increase urine production. Drugs that can actually, there are some drugs that you also give that can actually make the bladder can stimulate the bladder. If you give patient a cholinergic drug, that patient can have symptoms similar to AAP. But I think the slide said there's so many drugs, so many categories of drugs that can give symptoms. I don't want to use the word cause, but these drugs can give symptoms that you find in OAP, and that is the purpose of the history. When the patient presents with those symptoms, you take a history to find out whether he or she is on any of these drugs. Thank you.
Okay, thank you very much, because we are running out of time gradually and quite a number of questions. Let me just quickly, this one says that, can you explain the upper tract scan that you mentioned? If it's a scan of the kidney, the ureter, and the bladder. Then the second one says, I hope you got the first one.
Yes, yes.
Okay, the second one says, with geriatric patients with conditions such as vascular dementia and other forms of dementia benefit from conservative methods, or should we move straight to medical management, especially if the chronic medication conditions are under optimal control?
Okay, upper tract scan. When we talk about upper tract in urology, actually we are referring to scan about anything above the bladder. So bladder and below is what we call lower tract. I mentioned upper tract scan. If you think there's an obstruction, this patient may already have hydrouretas, hydronephrosis. So that's the reason for the upper tract scan. Then the other question, dementia. Well, basically, one of the first principles, luckily our geriatric physician is here. Basically, when a patient comes with symptoms and you find a disease that is causing it, if that disease is treatable, fine. If not, then you just focus on the symptoms. For dementia particularly, yes, there is no harm. The conservative measures, you should always consider them, particularly measures like timed urination, the measures like try if the patient can cooperate, the exercise, the pelvic floor exercises, you should consider them before drug therapy. But again, we must realize that when we are giving antimuscarinic drugs or beta-3 agonists, in reality, what we are doing is symptomatic control. And if a patient has a disease that you think is a cause of the OAP, or that you think is a cause of those symptoms, and the disease has no cure, then you focus on the symptoms. So conservative measures, if they are not enough, then you try the drugs.
Thank you very much. Maybe we can take 2 more questions because of our time. I don't know how many time do we have left. Dr. I'm sorry, Mr. Kennedy,
I'm here, sir.
Okay, how many times do we have left?
We have about 7 minutes left. About 7 minutes.
Okay, let's take 2 more questions. And Dr. Jani, you'll be brief, please. Yes. So, what is the way forward for drug-induced OAP, especially when the said drug properly controls the patient's condition, such as hypertension? And I hope you got that.
Yes.
And the second one, can OAP occur in young age group, less than 35 years of age? And can sex be a predisposing factor? So maybe just take those 2.
Yes, OAP certainly can occur at any age. It's just that it's more common after 40. Yes, sex, well, a lot of patients will present with symptoms of OAP after sex. This can be from many factors. It can still be from UTI, from ascending infection. Drug-induced symptoms of OAP, the reality of the matter is that when there's an alternative, you give, but there is no alternative, then you don't abandon, particularly a drug that is keeping a patient alive, like an antihypertensive. there are no alternatives, then the patient will have to try and probably live with the symptoms, and then you try and give drugs to counteract those side effects. But there are no rigid rules to this. Okay.
Thank you very much, Dr. Tijani. I want to say that today has been a really worthwhile time. And once again, I want to sincerely appreciate our lead presenter for that brilliant presentation. So lucid and very simple for even everybody on this platform to understand. And I know he has made it so simple because he is conscious of the audience. And I know that the variety of audience will have benefited. And living here, we want to begin to address the need of our patient. One thing that I must say here is the quality care that this patient deserves. And as much as possible, when you need to refer, please refer. We have highlighted those things that you must look for when it is time for you to refer. And I think you must bear it in mind. As much as they have given us the opportunity to have an understanding of how to take care of them, because they can all take care of these patients, we must also bear in mind that we must reciprocate by making sure that we don't complicate the issue for our patients. That is actually what makes the best healthcare provider. And so, on that note, I want to say that it's been a wonderful time today spending with our participants. And I want to also appreciate our audience for this wonderful privilege they've given us to speak to them, and also for the benefit of our patients. And also, let me also appreciate the Getz Pharma for giving us this opportunity to share with a larger audience the care of these patients when it comes to the role of primary care in the management of overactive bladder. Thank you very much. So over to you, Mr. Is Dr. Funshaw there? Hello? Is Dr. Funshaw there?
Okay, sir. Before Dr. Funshaw comes on, can I
Dr.
just
Funshaw
address some? Not yet, but before he comes on, can I quickly address some questions on Solifen?
Okay.
So we've got questions on cost. The cost of Solifen is 2,000 naira for the 5 milligram and 3,200 from Getz Pharma for the 10 milligram. We also got questions on side effects. Like Dr. Tijani already mentioned or made reference to, the main side effects of anticholinergics, just like Solifen, still remain dry mouth and constipation, and any other side effect that is peculiar with anticholinergics. Also, we have questions on drug interactions. This includes oral contraceptives, warfarin, digoxin, any drug that is metabolized by the cytochrome P450 pathway. And then we have question on in what cases is it contraindicated? Uncontrolled glaucoma, because of course of the anticholinergic pathway, gastric retention, or any hypersensitivity to sulfenacin as a molecule. But overall, the benefits of Solifen remain. In a pack, we have a question on how many is in a pack. That's 10 in a pack. Then is it safe in children? Solifen is registered in Nigeria for use in patients 12 years and above. We need to put that into consideration. Any other use outside the registration permit is due to the physician's discretion. So overall, that's all about Solifen, and it continues to be an efficacious medication which prescribers all over the world have found useful and giving support to their patients with OAB. So over to Dr. Funshaw. Thank you.
Hello, is Dr. Funshaw on now?
Yes, he is. Dr. Funshaw, unmute your mic. We can, yes. Great.
It has been a wonderful presentation. I would like to thank our guest speaker, Dr. Tijani. Even I would like to thank our moderator, Dr. Lukiri. Even with our little, we just have to bring it in a very little short time. We really appreciate And I want to believe very well that all our listeners have actually gained a lot from this wonderful presentations. Get Pharma is actually trying to bridge the gap to make sure that our patients actually have a good quality of life in various facets of the healthcare providers. And this actually brought us to the podium of why we believe that at least at every sector in the healthcare providers, there should be a way in which we are bridging the gap. And that's why Get Pharma, as a company that is actually known for this event, we want to thank everybody, the listener, for their time. We want to also thank even Get Pharma for making it possible for people to bridge the knowledge gap, even between the healthcare providers. And I want to thank you, and I want to believe that with these presentations, there will be an improvement even in the attendance to AOB cases all over the nation. I want to say once again, I bring greetings to office, and I want to thank even the organizers, the candidates, Afolabis, and even the CM, our country head, and the office staff for actually making this date a day to pass. And once again, I want to thank Dr. Tijani and Dr. Luwukiri and all listeners for being a part of this program. I want to say thank you very much for your time, and may God continue to be with you all.
Thank you very much, Dr. Funsho Oloruntoba. It's been a wonderful session today. And I must say here to my colleagues and family physicians that we all must have an understanding of this topic, and also be able to understand the fact that this medication issues, let us be very, very careful when we are making prescription, especially when it comes to some of these side effects. That means you must have taken a very good history before you recommend it, especially for the elderly. I must say that some of these medications could cause falls in the elderly, as you know. Some of these anticholinergic medications can be exposed to falls in the elderly. So please, as much as possible, when you are looking out for this patient, please take a very good history. Do a proper physical examination, investigate the patient very well, and when we have seen that there is need for you to make an appropriate referral, after you have done what you need to do, then based on the indication for referral, please do it appropriately. Once again, I want to thank all our listeners and participants for this brilliant presentation. Thank you once again.
Okay, all right. Thank
Over
you
to
so
you,
much,
Getz Pharma.
Okay, yes, sir. Thank you so much, Dr. Luwukiri, for making the moderation of this event a successful one. And I would like to especially appreciate Dr. Tijani for the wonderful session. I believe as a result of this webinar today, every primary care provider is more confident to identify and even intervene for patients that are currently burdened with overactive bladder. And if when we see the need, Solifen will be the top choice in this class of patients. So in closing, I would like to also make comment to, for those of us that our questions were not addressed in the course of the webinar, we would actually reach out to you via mail. You get answers to any question that has not been addressed. And for those that had challenges, maybe at some point of the webinar, the video of this webinar will also be later made available to us. The link will be shared to us via mail. And for every participant of this webinar, CME points will be made available as well to you. So thank you so much for your time. Have a lovely weekend and week ahead. And we trust you help all your patients on their journey to continence in addressing the bladder symptoms of overactive bladder disease. So have a lovely day ahead. Hello, Kenny.